Thank you. Thank you so much for this kind words. So just share my screen and we'll get started right away. Well, hope my slides are visible and I'm audible. So a very good evening and a warm welcome to everyone. And at the outset, before I begin, I'm going to take this opportunity to congratulate the organizers and especially Dr. Rahul for having put together this wonderful academic webinar, and also thank him for the opportunity. So I know we've had a lot of discussions on metastatic, recurrent and metastatic head and neck squamous cell carcinoma. So over the next half an hour or so, we're going to be talking on locally advanced head and neck squamous cell carcinoma, focusing on oral cavity cancers and looking at the current concerns, challenges and controversies that we have in the management of oral cavity, locally advanced head and neck squamous cell carcinomas. And also, while we're at it, we're going to be touching on a few important updates from ASCO 22 especially related to our Indian updates. So I'm going to begin with this. I think the one key thing that probably is important as far as locally advanced head and neck squamous cell carcinomas is resectability. And we know that when it's potentially resectable, the prognosis definitely is much better. You're talking about a survival, 5-year survival of between 30 to 40%. If it's resectable, and it drops down to around 10 to 15% if it becomes unresectable. And how then do you decide to choose between surgery? I think, we always talk about resectability and operability. Let me tell you that they're slightly different paradigms together. Resectability actually accounts for the anatomical location and also the radiologically being resectable, whereas operability depends on the patient factors, like a patient's given comorbid conditions, fitness, performance status, and so on and so forth. So I think those are key differences between resectability and operability. And again, if it's not operable or resectable, then you would definitely look at contemplating radiotherapy, or if the patient is not willing for surgery or is keen on organ preservation, then also you would look at radiotherapy as an option. And we all know that the tumor site definitely influences treatment decisions, where we look at organ preservation as being looked at predominantly in larynx, oropharynx, and hypopharynx. In oral cavity, we primarily look at surgery and reconstruction or chemoradiation. So with that, I'll probably open it up for the discussion, and I'll probably begin with our surgeons, Dr. Deshpande and Dr. Sangeet Agarwal. So how do you look at defining resectability and operability, and what is this term called borderline resectability as well? Is it always possible to segregate the patient upfront into these above 3 categories? So we'll begin with Dr. Deshpande and then Dr. Agarwal.
Yeah, good evening, everybody. Now, yes, we kind of divide patients into a locally advanced, kind of early cancers, borderline resectable, and locally advanced or unresectable cancers. And this borderline resectable cancers is, to some extent, it's a subjective kind of a group which is there. But then there are kind of now there's a recently published paper from Tata Memorial Hospital which kind of has put down these criteria for borderline resectability of oral cancers, and which has put these criteria as buccal mucosa cancer, which has with the edema going right up to the zygoma, or kind of a disease which is reaching up to the a high infratemporal fossa, or a base of or a tongue cancer which is reaching up to the hyoid. These are kind of or a borderline resectable operability of a neck node. But obviously, a borderline resectability, there are no clear-cut defined criteria. Like if you see a TNM classification or something, there is nothing like a borderline resectable. So there is a lot of subjectivity in a borderline resectable or head and neck cancer or oral cancer.
Fair enough. Points very well taken. Dr. Sangeet, would you like to add something? And
yeah, I agree with Dr. Mandar. Basically, in buccal mucosa and in tongue CA, there is high infratemporal fossa disease, means when there is frank involvement of lateral pterygoid or temporalis muscle. So this is inoperable for me. And in samely in CA tongue cases, the frank involvement of the base of tongue, whole of the base of tongue, and inferiorly reaching up to the hyoid bone or involvement of the hyoid bone. So it may, I will consider these cases as unresectable. So, and in larynx cases, when there is frank involvement of bilateral piriform fossa and prevertebral space, when the disease is reaching into the prevertebral space or involving the vertebra also. So these are some cases which we can say these are unresectable cases.
Fair enough. I think I completely agree with that. And I think, like Dr. Deshpande was rightly pointing out, we have the TMH indications as well, which is edema extending up to the zygoma, or involving up to the hyoid bone, or infratemporal fossa being involved, skin involvement, vallicular involvement. All of these make it borderline resectability as well. So I think that's already been pointed out. So I'll just move on to Vikas here. Vikas, what are the indications for neoadjuvant chemotherapy that you would use at your institute, Vikas?
Sorry, I missed the question.
No. What are the indications for neoadjuvant chemotherapy or induction chemotherapy in oral cavity head and neck squamous cell carcinomas that you would employ at your institute, Vikas?
So we had a beautiful publication probably 5 years back. We didn't have much data for as where the induction chemotherapy does play a benefit. But yes, when the edema reaches up to the zygoma and crosses it, but it doesn't, in those cases where the disease is creeping up to the low ITF.
Yeah, so I think you're pointing out the fact that if it's borderline resectable, I just want your thoughts on, like, say, for example, if the patient presents with the trismus, because those are very soft indications. We would do that at AR as well, when we were there. So I just want in terms of your own practice, as how do you do it in somebody who's got resectable disease or borderline resectable disease as well? Because just practical points.
So again, saying that I believe when we discuss with the induction chemos, there are a lot of issues with when we deal with some of the times when there are financial issues where we always have those constraints, whether the patient, even though fit for the surgery, but yes, the post-op, you feel that the morbidity is going to be so much that he's not going to survive the process for the complications, as well as I always tend to do a DPD testing upfront for all my patients, because I5 is a notorious drug. 30% of Indian patients tends to have the mutation associated with it, and that's why we have a beautiful trial presented in ASCO 2022 for the 2-drug versus the 3-drug regimen, where the 3-drug was even though found to be superior, but 2-drug was non-inferior. And for those where mutations, I prefer to have a 2-drug regimen rather than going for the 3-drug regimen. Also, where the patients disease reaching up to vallicula, I'm a very soft indication where we use induction chemotherapies. Also, as you said, when trismus, when you don't know, especially with trismus, I tend to examine those patients under anesthesia. So it gives you a good idea as where the disease is actually when you examine them. It gives you a good idea under the anesthesia as how much deep inside the disease is. And
okay, so just one quick question there. I mean, like, do you believe that there's a role for induction chemotherapy in resectable disease, for example, T4A, in oral
a very
cavity?
important question, I must say. So again, we had a beautiful paper out of it for the mandibular preservation. So if you look at the just recent publication for us, we published that sometimes the quality of life is very important for the patient. So even though we are going to resect that mandible, and you find out that the post of the dentation, the numerous issues associated with it. And if you give them an option of preservation of that mandible, the preservation of mastication, that's very important. And induction chemo is going to give, especially in T4 disease, reaching up to the, not involving, but up to the mandible, and you preserve those mandible. I believe that's an important area of induction chemo for me also.
True, point well taken. I think you're talking about the phase 2 data about mandibular preservation as well, and that's a phase 2 data. We'll get to that a little bit later on. But again, as far as resectable disease is concerned, if you look at the data, I think this is one trial which looked at induction followed by surgery. Again, there was no difference in the local regional recurrence or distant recurrence in overall survival. Yet another phase 3 RCT, again answering the same question, especially in oral cavity squamous cell carcinomas. Okay, no difference in local regional recurrence distance or in overall survival as well. So again, back to our surgeons, can we actually look at changing our excision or a surgical excision based on the neoadjuvant chemotherapy status or induction status, or do we still have to stick to the pre-neoadjuvant chemotherapy imaging? Dr. Deshpande and Dr. Sangeet.
So coming to the neoadjuvant chemotherapy, as going to the previous question, it is given under two circumstances. Number one is to make a borderline kind of case operable. So for which there were two previous studies which were there. One was a Lysitras trial and second was Zong's trial, which you showed. None of these trials showed that there is any improvement in survival. And second, now the Tata's retrospective data which has been published. Second is for organ preservation, the phase 2 trial, which has been again coming from Devendra's paper, which was published at ASCO, which showed that there is almost 47% preservation of mandible by giving a neoadjuvant chemotherapy. There is no detriment in kind of survival by giving a neoadjuvant chemotherapy. Yes, it is not this is the paper. This is not a kind of a phase 3 data, and they are doing a phase 3 trial over there. So I would say, so in this, we don't have a phase 3 data, but phase 2 data shows that in select group of patients, there is a data to support giving neoadjuvant chemotherapy. Now,
fair enough.
Yes, so this is
so I just wanted to know, I mean, like, does the margins or does the surgical excision, extent of surgical excision, is it based on the pre-op imaging, or is it based on post-neoadjuvant status?
So
how do you go about that in practice?
We've been discussing since ages how much there should be. Now, this particular trial which was done, they did not kind of go according to the previous margins. They went according to the new margins. Now, how you should be exactly going according to the previous margins, or whether you should be going according to the new margins, we just have no data about it. Most of the people believe that we should be going according to the previous margins. But if you go according to the previous margins, then you should be resecting the mandible in this patient. So obviously, we just don't have a data to support according to, or if it is inoperable or prior to chemotherapy, then it still remains inoperable. So, but yes, you need to be much wider if you are going according to. So we don't have any kind of a randomized data how wide you should be.
No, fair enough. I think I was just trying to draw a parallel here. Like, for example, in breast cancer, when we do breast conservation surgery post neoadjuvant chemotherapy, we look at doing it based on the current imaging rather than on pre-op imaging.
So
I was just trying to draw a
parallel. Doing a tattooing or something so that's to take a wider margin kind of a thing, but we don't have a kind of hardcore data how wide we should be going.
Absolutely. So we'll get Dr. Sangeet's view as well on
yes.
that.
Yes, definitely. After NACT, we will take at least 1 to 1.5 centimeter margins, but we can't take previous margins, means original margins. Okay. So it is a very long debate.
Fair enough. Yes. I think you can always argue both ways, but I think that's definitely there, because we always, in the current era, we always talk about less is more and de-escalation strategies and escalation strategies. So I think that it's fair enough to actually put it down that way. So I'll bring in Dr. Vikas again. So Vikas, I mean, like, if at all you do that, I mean, like, what is the risk of progression, and are we actually missing out on an opportunity of curative intent of treatment by actually doing induction? Vikas? Is Dr. Vikas there? Okay, I think that's one of the major drawbacks or disadvantages with doing induction in resectable oral cavity squamous cell carcinomas, because there is a risk of progression to the tune of around 20%, and you're actually missing out on an opportunity of curative intent of treatment as well. And this was the study that we've all alluded to: mandibular preservation, 47%, close to 50% could actually preserve their mandibles. But remember, this is phase 2 data, and the authors themselves concluded by saying that this needs to be validated in a larger phase 3 RCT. So this again was another very interesting publication from my good friends and colleagues from Malabar Cancer Center in Talasheri, Manu and Praveen, who interestingly happen to be good friends and colleagues. So do you see this as an alternative? I'd probably begin with again Dr. Deshpande here. I know we always talk about in large volume centers where there's a lot of waiting time and patients have to wait for at least a month or a month and a half before they actually go under the table. So, is this sort of a perioperative oral metronomic therapy make sense to you, at least in a low middle income country like India? Your thoughts on this? And we'll bring in Dr. Trinanjan as well.
No, definitely, because see, at the end of almost every presentation, there was a question asked that is there any role of neoadjuvant kind of immunotherapy or neoadjuvant targeted therapy? This was a question which was asked at the end of every presentation which was made. I would say, why not neoadjuvant metronomic kind of when patient is waiting for it? So definitely there is a role for it. Especially, I would say, in a sense, in a setup where patient is as such waiting for the surgery, why not metronomic? I would say definitely there is a role.
Fair enough. Dr. Trinanjan, your thoughts as well, quickly before we move on.
So we see it often, like for once we see after the surgery for adjuvant, that at times, and because working in Mumbai, we treat many patients from TMH, so it's quite. I won't say it's an infrequent practice because of the waiting people receive, especially for the last 2 years during COVID time. Also, many people have received. I guess a lot of data might have been gathered from that as well, especially in the first wave and second wave. I guess we don't have much supporting data. Of course, we have Vijay's paper on metronomic on every aspect, but that's after the treatment, like after completing your adjuvant as a maintenance, as a neoadjuvant metronomic option. Maybe you have to wait more. That's the only answer.
Yeah. So interestingly, Dr. Vijay's paper also had paclitaxel with carboplatin with oral metronomic chemotherapy as well, where they used a triplet of methotrexate, celecoxib, and erlotinib. I'll show you that data as we move along. But again, back to Dr. Sangeet. So, can you just help us throw some light on this contralateral neck dissection? When would you actually do a contralateral neck dissection in oral cavity squamous cell carcinomas? Just oral cavity.
So I have basically in the when the cancer tongue, the tumor is reaching up to the midline, means when there is involvement of the midline or just crossing the midline, I will address a contralateral neck. And the another factor is if the tumor is not reaching up to the midline, but during surgery, I found level 1A node. So level 1A node is my criteria to address opposite side of the neck. And in all other buccal mucosa cancers, or so when the tumor is just crossing or reaching the midline, I will address the contralateral neck.
Okay. Dr. Deshpande, you agree or you have any differing thoughts on that?
Yeah, similar this thing. Or I would say if there are multiple bulky nodes on going right up to the entire neck is full of nodes, perhaps we know that there is a very high chance of failure on the contralateral side. Not that just one or two nodes. If the neck is, if there are multiple nodes on the neck, I would perhaps sample, do a contralateral supraomoid neck on the other side.
Okay, fair enough. And so any takers for this PET-based surveillance? I know this was in oropharyngeal malignancies based on the PET neck study, where, even if patients had a residual disease of less than 1 centimeter nodes, they were kept under surveillance with PET-CT imaging after 12 weeks. And so any takers for that as opposed to doing a, vis-a-vis a salvage surgery versus a PET-based surveillance? Dr. Deshpande and Dr. Sangeet.
Yes, in a sense that we are routinely doing a kind of a PET-CT between 10 to 12 weeks post kind of a chemoradiation or whatever, the radical therapy which has been given between 10 to 12 weeks. And if there is a kind of complete response, or if there is a node which is less than a centimeter size, then we are not doing a routine salvage neck dissection the way we used to do it prior to the era of PET-CT scan. We are not doing a salvage neck dissections.
Fair enough. I think that's probably important for us to take home. Dr. Sangeet?
Yes, definitely. I agree with Dr. Deshpande. So basically, if there is complete regression after, or on the basis of PET-CT, we will not do the salvage neck dissection.
Perfect. Yeah. So is Dr. Vikas here, or otherwise I'm going to have to bring in Dr. Rahul sir to actually help us out with this part of the panel discussion. Is Dr. Vikas around? I think probably he must
doesn't seem like right.
Okay, so I'm sorry, I'll have to bring you in here, sir.
No problem.
So just these three scenarios. You have a bulky cervical lymph node with a tongue with engagement of carotid vessel. We know it's probably inoperable up front. And then buccal mucosa with intracranial extension. what are the chances of conversion to R0 resection, as you know, when you start off with induction as opposed to doing this definitive chemo radiation?
Yeah, I think the conversion to surgery is bleak in this patient, because majority of these patients, when you assess upfront, and I'm speaking in front of a couple of surgeons who are there, and they may probably mock me in the background also. But you know, we decide the operability upfront. I think we unlike the other diseases, other types of cancer, we decide later on. We usually treat them as an inoperable case, and either with a definitive CCRT, that is the way to go forward in this patient. However, yes, neoadjuvant chemotherapy followed by the CCRT is another option in this patient.
So while you read it quickly again, sir, I mean, like, if you look at all the studies, even in the unresectable setting, both the Paradigm and the DECIDE study, both of them are unfortunately negative. And there was no difference in RFS and overall survival. Probably the key difference is where it was, I mean, like, they were not powered adequately enough, and they could not complete their poor accrual as well. See, the plan for 400 patients ended up only 280, recruiting only 280. Same way, 300 patients, 140 patients only were recruited. So probably one of those reasons as to why you're not being able to see that these trials were actually positive. So probably if somebody were to replicate this in an Indian setting with a higher number of patients, probably you might end up seeing different results, and we'll probably get to that. So this was again data from TMH Mumbai, Indian data, retrospective data. And if you look at it again, 40% had a response and actually underwent surgery. And if you look at the number of patients who underwent surgery, the median overall survival was much better, 19 versus 8 months. So I think, you know, definitely there is a case, at least for us in India, and a low middle income country, where we can look at doing neoadjuvant chemotherapy, especially in borderline resectable. And this was another study again from Kidwai, Bangalore, where they looked at T4B, oral cavity squamous cell carcinomas, 2 to 3 cycles of induction, resectability around 20%. So, you know, you're looking at around resectability rates of around 20 to 40% across groups from India, be it from Kidwai or TMH. And the median overall survival definitely was much better in operated patients versus non-operated patients. So Vikas is back. Good to have you back, Vikas. So you're just in time. So, so you know, this was the update from the MAC-NC as well. So Vikas, quickly, your thoughts on unresectable disease. Do you believe that induction chemotherapy has a role there, or is it only definitely concurrent chemo radiation there?
I always am a fan of induction chemo. So I always feel that, yes, it gives you a test for the biology of the disease. And that's where it is important that we need to look at the Indian population. Wherever we see those McKenzie trials or the LSERAF studies, I always feel that that population is not the Indian population. That's a P16 positive population, a good biology, early lesions. For us, we see T4 fungating growths rather than those growths. So I'm always a fan of giving an induction followed by the consolidation or definitive therapies with it.
Fair enough. I think, fair enough. And this was one interesting trial that I looked up as well. We included patients who had oral cavity as well, albeit the numbers were much lesser as far as oral cavity was concerned. But clearly you could see that the induction chemotherapy did improve on the overall survival as opposed to no induction. And then they were randomized to cetuximab plus RT versus cisplatin with RT. And in that, probably cetuximab plus RT, probably in cetuximab plus RT, the hazard ratios are slightly much better. But again, I think, this is pretty early data. And I think, probably this is how I would look at summing it up. So unresectable disease with chemoradiation, you're only, looking at a survival of around 10 to 15%. Whereas neoadjuvant therapy, you're looking at least doing surgery in about close to 50% of patients. And the long-term survival is around 30%. So you're able to improve on the long-term survival from 15 to 30%. And rate of R0 resection with a triplet is definitely around 60%, with a doublet, which is only, without the PPF, with only TNP, without the PIFU is only around 40%. So these were the indications that we were actually discussing earlier as well, as in, borderline resectability, where we could look at doing induction chemotherapy, and all these factors still hold good. So if you look at 2 versus 3 drugs, these were the 3 key trials. The TAX324 was probably one key trial which looked at showing an improvement in survival with 3 drugs as opposed to 2 drugs. So I think this is Dr. Vikas was alluding to this as well, the incidence and impact of DPD. So this again was very specific in Indian data, where it was to the tune of around 8 to 10% as far as DPD deficiency was concerned. And we use the CPIC score, the Clinical Pharmacogenomics Implementation Consortium data, which we used to classify as poor metabolizers and intermediate metabolizers. So it makes sense for us to do a DPD assay if you're contemplating DPF, because this is what you were trying to highlight earlier on as well, right? So do you routinely do a DPD for all your patients with head and neck cancer?
Yes, because after doing this paper, we find out that the Western data and Indian data do not corroborate. So our population was 24, 26, 30% around. We have updated this also, and it's coming around 30%. And if you find that 1/3 of your patients are going to have a grade 3, grade 4 tox after your induction chemos, you're going to look back and say and decide whether the therapy is going to be useful or not for them. So that's why very important test, a simple test, but very, very important.
What was the incidence in your practice? Because I mean, like, what roughly the ballpark figures as far as DPD deficiency is concerned, both homozygous and heterozygous?
3 out of 10 patients whom I recently tested came out to be DPD positive. So again, that's fairly
Pretty
corroborative.
Okay. So I think fair enough. I think, I think probably in the Indian subset, definitely, yes, it is higher and it makes sense for us to do it. So, while you're at it, probably, how interesting is this data to you as well? Because, we're looking at paclitaxel with oral metronomic chemotherapy in borderline resectable or unresectable tumors, again from the TMH group. So, I mean, like,
very, very important and a very relevant study. We all are doing it unknowingly for our unfit patients, those who are cisplatin ineligible patients, those patients who we think don't have the finances, those patients where we think the triple drug therapy is going to do much more harm. And that's where this data plays a very important. A simple regimen of paclitaxel and adding oral metronomic produces equivalent results as compared to the DCF regimen without causing much side effects, much hospitalizations. So definitely, I believe future is the way to go for the head neck cancers. It is going to be an ALL-like protocol where when you every week we have the vincristine doxorubicin injections for the BFM90 protocols. We are going to have that carboplatin paclitaxel regimen, and every day, like the steroids, we are going to give geftinib, celecoxib, and then once a week methotrexate injections. I believe that's the way acute leukemias used to be managed. Now we have a prospective acute head neck cancers to manage the same way.
Fair enough. But what about the toxicity? I mean, like, what about the toxicity, especially with the triplet? I know we had this, data from ASCO 2020 as well, where 3 drugs was definitely better than 2 drugs. But how do you end up managing the toxicity and then, having to establish a central line and all of that? How do you look at doing that in practice? Do you do a bolus or an infusional 5FU?
Dr. Krupa, sir, last couple of minutes to conclude.
Yeah, sure. Well.
If I'm doing DCF, I'm doing a infusional 5FU. I don't do the bolus of 5FU.
Okay, fair enough. I think, in practice, we do a modified infusional 5FU. We don't go with the entire 48-hour infusion. So I think, it varies depending on, where you practice and the center as well, and also your own comfort and convenience as far as patient is concerned. So fair enough. Quickly, I mean, like, I know we've kept a radiation oncologist out of it. I'll just quickly get his thoughts on it. So what about, adjuvant RT? And, I mean, like, we know these are the indications from the ORTs in the RTOG trial, and adjuvant chemoradiation is probably only for margins with people who are margin positive extracapsular extension. So how do you look at risk stratifying them? And do you actually, depending on the dose, would you change the dose based on this risk stratification? How does it work, Dr. Trinanjan?
So the 2 definite indications of adding chemo are definitely margin close positive or nodes with extranodal extensions. There is some data about multiple node positive, maybe not even with extracapsular, but you have, say, more than 2 nodes positive or so, especially in the lower neck, maybe level 3 onwards, or the skip to 4. The intermediate risk factors, we have to wait for 0920 data before coming. Now for the dose, there are data actually also between 60 to 66, and frankly, there's no difference. Even teammates from the radiation oncology from our department also have done an analysis. So you have to give for the post-op bed a close to 60 gray dose, and the elective neck about 50 gray dose, whatever dose fractionation you use. Some data is there for the microscopic margin positive to escalate up to 64 or 66. Some centers do it for even node with extranodal dose level up to 66. But frankly, it is an institutional practice mode. If you ask me for doing now close to 5-6 years of this, I try to limit to 60 only for microscopic close margin, maybe 64 or so.
Fair enough. I think, that's probably you summed it up very well in a nutshell. So I think, that's the standard. And quickly before we wind up, I'm going to bring in Vikas here for your concluding remarks. Weekly versus 3 weekly cisplatin in the adjuvant setting. I know this was the Indian data, TMH data, which, which established, that weekly was not, could not prove non-inferiority of the weekly cisplatin over 3 weekly. So 3 weekly did remain the standard of care. But I wanted to just touch on the Japanese clinical oncology group JCOG data, which is the reason for the debate, which has shown that probably weekly cisplatin definitely does score over. So, is it time for us to change to weekly cisplatin? Is it less toxic, better tolerated, albeit the caveat that it's still Japanese data, but still, do you think it's time for us to change, Vikas?
So we have been doing probably 40 milligram per meter square with what that Japanese took population, because our paper was between 3 weekly and weekly. And when we give that 40 milligram per meter square, I believe the cumulative dose, if we are able to deliver more than 6 or cycles, that's what is important. 200 milligram per meter square is when I say that should go inside the body. So wherever we are giving it, I believe that's a very important. We also had an Indian study by Dr. Atul sir, and which also proved that yes, weekly 40 milligram per meter square is non-inferior. So 2 studies fairly saying that yes, weekly is a non-inferior regimen, but for a fit performance status patient, I would always prefer the 3 weekly regimen since it has been the standard. But at the end of the day, I'm not going to lose sleep if I'm giving 40 milligram per meter square with these 2 studies.
Absolutely. I think, like you rightly hit the nail on the head, the concept trial was in the definitive setting, and that was earlier on was in the adjuvant setting. So I think these are the criteria that we have. This is cisplatin eligibility. And this was yet another interesting trial that came out of ASCO 2020 as well, where you could use docetaxel as a radiosensitizer if the patient was not fit for platinum. So I think with that, I think we've run out of time, and we will probably, end the panel discussion here. And I must thank all my panelists for having been so interactive. Of both the surgeons, my radiation oncologist, and Vikas as well. So thank you guys for making it so interactive. Hand it over back to the organizers and Dr. Rahul.